things that I have prayed and just would give anything to see in 5 years, I've seen it now in 4 weeks. By day 2 of life, Luke started to go into a coma. The first 6 months of Luke's life were very traumatic, to say the least. He was in the hospital every week. We would get out for a couple days and be back. His pneumonia was just never really managed. For 6 months, he stayed at a brain damaging level. Every time I would see a doctor, they just pick one diagnosis to fixate on. So Luke has been given a diagnosis of CPS1, he's had a liver transplant, metabolic stroke, cerebral palsy from the stroke, and we also got an autism diagnosis. There were many nights that I would stay up crying, thinking, what can I do for him? Because I feel like everything I'm doing here is not working. Dr. Crawford takes us back, and he was looking over Luke, talking to him. He didn't treat Luke like any of his diagnosis, not one of them. He was looking at Luke to treat Luke what works best for him. This is a place of miracles. So before, I could never get Luke to dress himself. And the other morning I had his clothes laid out for him, and I was in the bathroom getting ready, and I walked back into the bedroom and he had already gotten himself dressed. He was completely nonverbal from the stroke, so never said a word, but he has started to talk. I was like, you get to go to clinic today and see all your friends. And I was like, are you ready to go now? And he said, yeah. And now he's trying, every night he's trying to sound out words. He actually sits at night and in bed and wants me to read to him. He's never done that before. He was not ever using utensils. And I've made videos of him since being here of eating his first cup of ice cream, literally from Chick-fil-A, because he can do it now. I just have so much hope for Luke's future, and just seeing the things that he's done in 4 weeks. I can't imagine what it's going to look like for him when we get home and we're doing home care. Who knows, maybe a year from now I will be sending y'all T-ball pictures and whatever he wants to do.
You're doing awesome, dude.
This place is restoring health, restoring hope to families, and truly changing lives, not only of the patients, but of the families as well.
Get started. So welcome, thank you all for coming. I am Jean Hawney. I am a speech language pathologist and a feeding specialist. I'm joined here with Dr. Taryn Townsend, a brain injury specialist and also a speech language pathologist. And today we're going to talk about what happens when a child has swallowing or feeding challenges after a brain injury. Most importantly, we want to talk about the caregiver's role. So this talk is not about perfection, and it's just about understanding patience and small victories. Let's see if this works. Okay, so I, again, am Jean Hawney. I've worked with babies and children across hospitals, rehabilitations, homes for over 14 years. I'm also the founder of Little Eaters and Talkers in Houston. Taryn here, she'll talk about herself a little bit, but she also brings expertise from the pediatric ICU and rehabilitation world. And so together we hope to bring home and hospital-based perspectives to today's discussion. We have both seen the incredible resilience of families, and being here at Team Luke has been really incredible and empowering. I love meeting all these families and just hearing about the journeys that so much of you have been through. It makes me emotional. But now I'll have Taryn.
Oh, thank you, Jean. So about me, 13 years of experience. I've worked across the lifespan. And so I've worked with adults and I've worked with pediatrics with medically complex injuries, especially brain injury, which is my passion. I went on to receive my clinical doctorate in speech language pathology to really solve a lot of these pediatric brain injury issues that we do have. Still a work in progress, but here I am. Currently, I work full-time in a pediatric intensive care unit. I also work outside of that, have worked in home health settings and so on and so forth, inpatient rehabilitation settings. And I speak at University of Houston as well as speak across the country and the world for that. So let's get started. Our outcomes, what we want to do today. Right now, we could talk about feeding and swallowing like all day. And tomorrow we can. We have space for families to come up to us privately and talk about some issues that you're having. So today, again, like Jean said, is our overview. We want you guys to understand feeding and swallowing challenges after a pediatric brain injury, which I assume that all of you probably already do. So that's a review. We can't teach you what you've already lived through. So we understand that. Hopefully not just learn your role as a caregiver, but empower your role as a caregiver. And then practical strategies to help in between that breakdown from home to therapy. So there's a patient I work with. I hope it works. Of course I do this wrong. Do I click?
You press on.
See, this is where I'm like,
There you go. And then you'll press play again.
Oh. So I want to preface this with every attempt matters. Even if it's not a good attempt that you think is good, these feeding attempts matter. And we'll talk more about how we can make them safe and whatnot, but this is a patient that I worked with in there, and it is not playing on the screen. In there, which I do not know why. I think it's embedded from Drive to PowerPoint.
No, it worked a second ago.
On the screen?
I do want you to see.
And so we're not suctioning. She has the speaking valve in place. She's on a ventilator. I had it muted from the computer. Yeah, because of the beeping. And so there she goes. And so you can kind of see she's wiping, and then we do suction in between each bite in there. You can see a little bit of that chocolate tinged secretions in there, but she's enjoying it. She does smile.
She wanted it.
In there. And we all understand the risks of that. And this is not where you're coming home from this and saying, she did it, it's okay. There are risks here. So we just wanted to get some engagement. How many of you have worked with a speech language pathologist? Right, good, because sometimes I hear when I've worked across the community that there was not a speech therapy consult during hospitalization. So I wanted to check. And then what is something you would like to learn today? So we're making this about the caregiver. So any questions? Again, tomorrow will be available. Safety, good, in there. So, and tomorrow again, we're available to talk about it. And so this goes to Jean now. Okay. Sorry about the delay.
Yeah. Well, we've got some cute stuff in here, so we want to make sure we can see it. Okay, so when a child experiences a brain injury, we know that things can change where they're swallowing and eating. That's just like speech, memory, movement. Things change, and swallowing is really complex. I definitely, when I'm working with a lot of my children, I'm like, every day we have to be so grateful for what we can do, because you can take things for granted pretty easily when you notice how challenging something can be to learn. So you might notice your child is having trouble managing their saliva, coughing during meals, getting tired quickly. So I just want to make sure we know. Swallowing safely means food and drink go down the right way. That means into the stomach, not in the lungs. And then aspiration, which is a word many of you probably know, is when food or drink goes down the wrong way into the lungs instead of the stomach. So safe swallowing means that. Doesn't always happen, and we're going to talk about safety and some risks that we take. But what's most important is to remember that progress is possible and that children's brains are super adaptable. That is called neuroplasticity. And if you don't know that word, I want you to know that word, because it's a very powerful word. And that means that we can form new connections with practice and the right support. So helping children relearn to eat. This is one of my little ones after a brain injury, and we're trying to get her ready for a swallow study. This didn't come quickly. It took a while before we could start trialing some of these foods. But as she goes, she's like, give it to me. I used to eat, please. She's relearning, right? These muscles must be retrained, and also building trust, which is really important, because not all kids right after, their accident are gonna be like, oh yeah, I want that again. Like, we have to build trust. And then most importantly, celebrate effort over perfection. Success may be a taste today, and who knows what will happen tomorrow. So we know, as I've already kind of talked about, like our brains change after our abilities to swallow and eat can change after a brain injury, and that it takes so much to be able to learn to eat and drink. Healing after a brain injury can take effort, and as caregivers, you're the most consistent and trusted part of the team. So we're going to talk a little bit about dysphagia. That is the fancy word for swallowing difficulties. And after a brain injury, it's common for swallowing to change. And sometimes it's subtle. So here are some signs to watch out for. You know, it might be coughing, wet and gurgly voice, frequent throat clearing, pneumonia. Usually I think what most people get scared about is pneumonia. Like that is the term that kind of gets like fear factored into you when there's changes to swallowing. And so we don't want that to happen, because if you're already medically compromised, it can impact you in a big way. So we definitely want to go into how do we prevent pneumonia, but also, like Taryn said, the only way to practice swallowing is swallowing. So we've got to meet somewhere in the middle. And not every child shows the same signs. Some children have what's called silent aspiration, and that just means that you might not cough, and it can go down the wrong way. So I'm going to show you a video of that. So as you can see, food goes down the back way, which is to the stomach, and then the front way, that's your trachea. So that's where the aspiration can come, is shown in that swallow study. At the hospital, we will talk about, yeah, of course. Actually, this is a good one to play again. So the back is your esophagus, okay? And that's where we want food to go. But if it's going down the front, that's your aspiration. And that's a big one. And so sometimes you can feed a child and you don't even know that they aspirated. I mean, they're looking at you in the face like smiling, and you're looking at the swallow study like, oh, okay, right? And so we have to figure out what is safe for that child. So this is important, because as we've been here today, we've heard people use the word failed, and we don't want you to think that way. Taryn had a really good analogy earlier about, like, would you say you failed your MRI? Or would you say you failed your x-ray, your chest x-ray? No, it's just a moment in time with so many variables, and it's just a diagnostic marker or a way for us to come up with a game plan. So we generally will say, try not to use the word failed, but more, it was just a study, and we have to figure out where to go from there. So with our swallow studies, one of our biggest things, and this is where I'm really going to push you guys as caregivers to really advocate for your babies, is you can't just walk into a swallow study and have never eaten before. Like, it doesn't work that way. And I know there's so many catch-22s on that, so we'll go through that. But oral, motor, and sensory readiness, right? That is like, can your baby tolerate food in their mouth? Can they tolerate a spoon? Did they let you brush their teeth? Are they often gagging or in distress when you're presenting with food? Well, we've got to work on that oral defensiveness. A baseline clinical swallow. So before you go to a swallow study, generally speaking, we want to try some things. We want to come up with our game plan. We also have to think about barium is often used in a swallow study, and think of it as fluff, which is very mushy and thick, and not all kiddos can tolerate that. So you really have to think about, like, okay, what are the preferred foods I need to bring to this swallow study? Don't give my kid applesauce if they don't like applesauce. And just kind of really think about it ahead of time so that it could be the most effective. And that goes into timing. So I don't want to do a swallow study right after an accident. Like, pump the brakes. Let's give this baby a second to kind of recover and come up with our plan. But also, I don't want to wait too long, because then maybe we won't have been eating for so long. So that's another part where we need to make sure we're practicing not too early, not too late, and that if your child is not eating, they're not ready for the swallow study. So, so that's my big takeaway for that one.
And so that goes into it. Now, I want to go back to swallow studies. We talk about that, but sometimes the doctors want it right away, or your speech therapist in the community won't do PO without the swallow study. So it's really, really hard. So we'll talk a bit about that. Oh, I'm losing my voice, the speech therapist. It's because I was so excited earlier and just talking so much. But yeah, so your role, and again, I'm not the caregiver, so I don't want to tell you about what you already know and how hard you've already worked for your loved one. But you are the eyes and ears for your child between the sessions, before speech, before their appointments. You are that. And so you need to be encouraging, but I also know that there's this pressure. We want the kids to eat. And so we need to also remove that pressure because that does have negative effects. It's detrimental to your spirit, to yourself, and it's tough in there, but you want to also encourage and push your child. So kind of managing that. And then safety, supporting safe feeding. You are the central team member. Your support makes the difference. You know, I'm sure, and we'll talk about the word no, and I'm sure a lot of our children with moderate and severe brain injury have been told no. From the get-go, the recovery model that they've given you is something it's just met with no, and so we need to talk about that. Your team, it's not just speech, I like it just speech, but we work with other people. OT, dietitian, your physician, your nursing staff, your caregivers, you guys all create this team approach. If you don't have them, and this is not just talking about the hospital, but at home, you can get these people on your team. I think occupational therapy and speech therapy can go hand in hand, but I want to talk about like having a dietitian. We also have other care members that we'll talk about. The first role, safety, but also are we getting good nutrition and hydration? So if we do progress to oral feeding, are we eating enough in there? Do we still rely on the tube feeding? Are we looking at supplementing our tube feeding? Are we looking at transitioning to complete oral feeding? We'll talk about that. Participation in family meal times. I think we think that eating is just sustenance, but it's also social. You know, a meal is a big part of a family gathering. Think of Thanksgiving and how we can participate safely in things like this. And then quality of life. Eating is a big part of that return to a good quality of life. So we're going to go through each of the team approaches. Feel free to chime in, talk about this stuff. It's probably a review, but your doctor is not the enemy. None of these are the enemy, but they're the ones who do the medical evaluations. They are overall assessing growth. They'll have their growth chart. And so if you are just relying on oral feeding, they may look and say, well, we're losing weight. And so they might have some issues there. They also give you your orders and your prescriptions when you do come to a safe diet. But the biggest part in your recovery is they provide your referral. So your speech therapy, your physical therapy, your OT, your dietitian, GI, all the consultants, the orders come from your medical doctor. And so building a relationship with them is really important. How you can really advocate for your child, we just have 4 ways. Paint a clear picture of your child. You go to your medical appointment and they only see your child in that moment of time. They don't. They have 2 appointments before you, 1 after you. They may not have a great picture of your child outside of that appointment. So I love like videos, you know, bringing those in there, taking pictures, showing that true potential. Prepare questions. A lot of times you're like, I'll wait and tell the doctor, and then you forget, or the appointment goes so fast. So I cannot advocate, and this doesn't just go for doctors, but it goes for all your appointments. Have your questions ready, take notes. You can put a notepad on your phone, but have them there. Follow through with your part. If the doctors tell you to do something, do it. So don't go to your next appointment and things haven't been done. And then push for those referrals. Again, don't take that no for an answer, and again, we'll have some resources. Questions that you can have. Could my child benefit from a swallow study? Just even getting there. You know, we haven't had one since they were in the hospital a year ago. Push for that, ask for them. Are there any medical reasons that it could affect their feeding and swallowing? Reflux, medications, seizures. I mean, that is just a small amount of things that could be affecting their recovery. Sometimes those medications cause sedation. And so you're getting told your child's too sleepy to wake up and eat. And so it's been several months post-injury. It's been several months since your last check-in. We'll talk about those medications. It's not just SLPs and OTs that can support it, but dietitians, GI. It's not just up to us. So looking at a team and seeing different interventions to go about it. And what signs should you watch for when you do start eating? Your dietitian. Does anybody work with a dietitian in the community? Good. And they support, I guess, tube feeding, but they can also support working on that return to oral feeding. Similar to the doctor, they're going to look at growth, nutrition, and they're going to obviously provide the tube feeding support, but adapting textures, the recommendations, all those are important. And then creating that collaborative feeding plan. If you're working with a speech therapist, does your dietitian work with your speech therapist? They can. I struggle. It looks like it, but they can. That's something that you would have to advocate for. Jean works, I'm again hospital-based, Jean works in the community. Do you work with dietitians?
Yeah, I fight them. I'm not kidding. I fight them.
But how do you get to that point? Because
Call 'em on the floor.
because of the family's requesting you to do
Well,
that.
or I'm requesting the dietitian, and then I don't always love the recommendations that are made, and then we have to talk about how to meet in the middle. But I do follow a more holistic food-based approach to eating. So when I'm having kiddos that are just pumped up with all these formulas, I really advocate and try to find a dietitian who's going to meet me in the middle. And I find that my hospital-based dietitians are very numbers-based. And so then I provide resources of outside of the hospital to find someone who's going to be a little outside of the box thinker to get us to the same goal.
And so they're out there.
They are out there.
They're out there.
Honestly, I find a lot of amazing ones on Instagram. No, they're real dietitians. They're not just like nutrition counselors, but like they can work virtually. They don't need to be in your face.
Mm-hmm.
So, but you guys are speech.
We are
Your
speech.
speech.
Okay, so we're 5.5 years post-accident. I've never had the dietitian say, "Hey, let me help you get him eating food again."
That's why my hospital-based dietitians are so stuck in this like numbers game.
They just want to give him powders.
In. Yeah.
It's very numbers-based, yeah.
So that's where ideally your feeding therapist would be like, how do we get the food in? Right.
It is. And so this presentation is about the caregiver's role. And so
what do you do?
What do you do?
Do you
And
just
so-
accept that answer?
I don't know. I didn't know that I could. I didn't know the dietitian. Yeah, I guess I just didn't know.
But your dietitian doesn't know what your child can do if they're not aware, if you're not showing them, or that's where it's the team.
Is it an outside of the box thing for a speech therapist to talk to a dietitian?
No, even in the hospital setting, I work with the dietitian.
Yeah, because we usually have to tell them what diet they're on. You know, if they're on a pureed diet, then the diet has to be able to be accommodated by the dietitian. And if I have children on special diets, then I need the dietitian to kind of help me think of ways to get that. They do love their formulas, though. They love.
I think it's more so, and I don't want to speak for dietitians, whoever's watching at home, or anything.
But my
in there,
friend
we're not
Katie's
seizing
coming
trouble.
tomorrow, and so.
No one's the enemy, right?
No one's the enemy. We work together.
And everyone's different.
And I think we all have different point of views. And in a way, maybe the goal for the dietitian is to maintain weight. And so possibly transitioning to oral feeding does have a decline in weight. That child's figuring it out. And that's against the goals of the doctors, the dietitians. And so figuring that out and coming to a common ground. So
And
there's
asking questions.
So it's not speech versus dietitian at all,
No.
but it's a collaboration. And so the dietitian does play a meaningful role on the team. What you can do, report concerns, carry over your recommendations at home, track eating habits or responses to their feeding and saying, okay, well, before they have therapy, the feeding timeline or the volume just doesn't seem to be appropriate. So things like that as a caregiver. But advocate your preferences for that. And so questions. Is my child getting enough calories, protein, all the things? But what adjustments can be made if my child gets tired before finishing meals, or if they are transitioning between that, or just looking at how they're tolerating their tube feedings.
The last one's for you. You see it? How can we safely transition from tube feeding to oral feeding?
And so, and not just with tube feedings, but they also can have alternatives if you're refusing certain textures or food groups are working on that too. So it's not just the tube feeding that they can do. They can work with speech. And so, again, I think some therapists, dietitians may be numbers based and stuff rather than looking at the ultimate picture of what's appropriate for the child, and then also looking at family and caregiver goals. So finding someone who meets the goals that you do have and making sure you're on the same page. I mean, Jean and I are unlikely match, hospital and home base.
But I was in the hospital for over 10 years, so I know what happens there, and now I know what happens at home. And I'm like, we start in the hospital right after our injury, and we just need you to be safe and get out. How do we get you out? The sooner the better, right? So then we can actually get to work. But again, our community-based therapists, just like we know with every doctor and medical professional and whatever, everyone has a variation of how much they know and how much time they have in therapy but I love what Taryn said. What are your goals? And have you voiced those goals? That's really important.
And so to keep going, occupational therapy, they can work on feeding too. So if you are on a wait list for speech, there are occupational therapists who are trained to work on feeding and swallowing. But supporting the sensory and fine motor processing, posture and positioning, super important. Adaptive equipment recommendations for feeding, positioning, again, all those, and promoting overall independence. I like to see that and work with them. What your role is in there is practice the strategies and carry over what they're teaching you. A therapy session is only a small fragment of time. So we need caregivers to take what you learn and use it. Advocate for comfort and dignity in there. So I had a family member reach out today about cup, and is it age appropriate? Yes, in there. She didn't want to say no, in there. And so dignity and using that's an important thing. Yes, we're working on feeding. We may have regressed and we're doing things that may not be developmentally appropriate, but they're appropriate for them. But we also have to look at that dignity. And so advocating that, not just with OT, PT, speech, and across the boundaries. Describe what you see and encourage independence. Some things, asking about sitting, asking about adaptive utensils or cups for self-feeding and things that, I'm feeding them and I want to grow that level of independence. What are ways that we can work together to adapt that? If they're oversensitive, they work on sensory issues. Or hyposensitive, they also work on building that up. And any exercise or activities. If they're not giving you a home exercise program, ask for one. Nursing. If any of you have home nursing, but they're around, they can manage your medical equipment, educate you, monitor feeding safety if you do have nursing in the home, and implement and support the feeding plans that they get. So if you do have nursing, share observations, fine-tune your routines, get clear expectations with home nursing, promote hands-on training, and again, advocate for comfort and dignity. So again, that's another important thing in there with nursing care. Questions? How can nursing support that feeding journey? You have goals for your child, right? And the nurse may be with your child longer than you are, And so what can they do? How can they support? This one's a tricky one because some nurses may not feel comfortable implementing that. And so kind of still working towards a happy thing. You don't want them to do the therapy and the home exercise program if they're not comfortable with it. But what supports can we do to work together so that we don't regress with those long periods of time? Tube feeding, nurses, when they work with that. So just working on that, and then how can I make meal times at home feel safe and comfortable? If they are feeding your child, you can get some carryover to learn what they're doing or if any strategies from them. Psychologist and social worker, this one's so important. I think it gets overlooked, but there's a lot of emotion that comes with it. I think feeding and swallowing is a big part of recovery and that being able to re-implement that. And so having the support of a social worker or a psychologist is important. Not necessarily maybe to support the child, but to support the caregiver. Because I'm telling you to do all these things. And it's hard. I understand. I can't understand that, but as a medical professional, I want you to feel supported and do what you need to do. So advocating for the support, talking to someone, celebrating the successes. Successes may not be returned to a full meal, but having them enjoy something that they haven't enjoyed since previously before their injury, even if it's one bite. Those are successes. Practice the strategies and use tools. And when I say tools, they're probably giving you those like emotional support caregiver models, but use them. They're important. You know, if you don't use them, you can't really benefit from them. So giving them a try. And so coping strategies. How can I support siblings and family members who feel stressed at meals and who don't want to do it or don't carry over because they don't feel comfortable? Resources and grants. Social workers are amazing for that. So seeing if there are any insurance issues or needing resources, a community-based social worker. I think I've heard from families that's how they got here today. And so using them, not just for just conferences and stuff, but even in your day-to-day life for interventions and equipment. And so that is important. And then us. We assess swallowing function, teach feeding, swallowing strategies, develop and drive a therapy plan, and teach and educate safe things in there. What you can do for us, if we do give you things to use at home, monitoring safety is so important. Don't go at it all willy-nilly in there. These are things that potentially can contribute to a rehospitalization. Practice at home as appropriate. Share your observations and your concerns. Any concerns you have, we're here. And then even working towards carrying over to school, which is a whole nother presentation.
That someone's going to do tomorrow.
We're like somebody in their return to school and working on that. I think that's ongoing. I presented at a conference this weekend. That's probably why my voice is gone. And working on building feeding and swallowing teams in schools is an ongoing dilemma. We're aware. So questions for your SLP. What are foods and liquids that are safest for my child? What can I work on at home? Getting that, just asking outright. Can you teach me the strategies that keep my child safe? How can I carry over? When should we assess a repeat swallow study, right? They may just kind of dragging it out. And so put that on there. You know, demand a timeline. Obviously, timelines aren't set in stone, but like let's talk about it. Like, what are we working on in the next 3 months so that we can try that? Again, there's a lot of issues with getting that swallow study, but getting some concrete information. What are our goals? And are we working towards a year? Are we working for 6 months? Do you not think another one is appropriate in the future? And then tell me why.
I'm sorry. So when would be a good time for like a swallow study? Say like they're working on something, and, you know, and then they already met that goal. I mean, I don't think you would go for a swallow study, but then kind of set up another goal, and then so like, when would be a good time to?
I think that one's a multifaceted one. Will be around because I think I need more information to why. Like, were we having gross aspiration? Where was it done in the hospital months before you made it home? What the goals were set for them to want to do that, and so demanding that from your therapist to give you like clear, concrete answers. For me, some issues would be like, it's been a while. Like, it can be easy as that. It's been 6 to 8, 9, 10 months a year. Let's do it. Let's check. There's some spontaneous recovery. We've been working really hard in therapy. Let's see that. Maybe a change in their swallow response. You're seeing levels of alertness increase. You're seeing better tolerance at the bedside. And so you want to see them increase that volume and do it safely. So there's a lot. We can talk after too.
Today I met a mom. Oh, we had a great story. She was telling me that her kid had been about maybe 6 to 9 months since the last swallow study. And on that last swallow study, they had the kid on thickened liquids. And I was like, oh, what are they practicing in therapy? And she was like, thickened liquids. And I was like, wait, why aren't we practicing something a little bit more challenging? She's like, I don't know. I don't know what happened in that swallow study. And she goes, but I'll tell you, I gave him a slushie last week. He drank the whole thing. And I was like, I think you should maybe bring that to your therapist and say, we need to start something liquids to get to that goal, and then decide when to repeat that swallow study so we can get off the thickened liquids. And I mean, it was funny. I was like, okay.
Safely.
That was a little, but I was like, how'd he do? She was like, he loves it.
Disclaimer. Disclaimer. So what caregivers can do when you hear no, you hear the no's, right, from your doctor, your feeding therapist. Ask why. Request good clinical reasoning. You know, they can't just tell you no and period. There needs to be a justification. And then sometimes their clinical reasoning, I mean, sometimes you have to be armed with those clinical observations, those ideas for it. Peer-reviewed journal articles, which is really interesting because it's like hard to find and to receive. And ask for interdisciplinary input. Go to your GI, ENT, get buy-in from other medical professionals to see if you can have almost like an army go towards getting that no. That no exists in our community. I mean, we get them coming into the hospital and their community-based therapist doesn't even want to do like water because they don't have a swallow study. But then they're not going to do well in the swallow study because they've never, in the most recent past, been exposed to things to swallow. So it's catch-22. I really want everybody to take that QR code of resources. These are resources that Gina and I found that can advocate for getting. What do you do when you hear no? They may be hard to find, and some of them are older, but just having them. And even if you didn't read the whole thing, you can pull up that abstract and kind of take the bottom line from them if you can't access them, because I know that it's almost like research is hard to, like, it's so safeguarded, you know, it's hard to access.
I'd like to, and you don't have to do it right now, but I'd like to talk further about swallow studies and like how to prepare for a swallow study.
Absolutely.
Next slide.
In there, and then I also want to say, remember, no can be not yet. So no could be not right now, and they might have a valid clinical reasoning. But what is a safe solution? This is taken from a famous for speech.
Very well.
Well-known speech, I'm like famous for us, Dr. Arbinson. And so this is just like, what is a safe solution? And all of this is taken with a grain of salt. This was in an article that she wrote that was based in cerebral palsy literature, which kind of covers a brain injury sustained very early in birth or right afterwards, but may have some similar characteristics to some of our moderate and severe brain injuries. And her rationale was that children can cope with minimal taste for pleasure. So keeping it pleasurable, low expectations in there, but having some exposure. Purees are often much safety. They're more cohesive, can move slower. And when we say purees, not a spoonful, but maybe a little delivered taste of it. But water is the safest. If water is aspirated into the lungs, it tends to be safest for your body to break down without causing biggest barriers. But skipping there, oral hygiene is of utmost importance in there. So I don't, working in the hospital setting, I don't recommend NPO, which is nothing by mouth. And I'm working in the ICU. A limited volume that's pleasurable is pretty much the way to go, especially as they move towards discharge. And that's something that we're doing from the hospital. And so that's...
Does that kind of answer your question, though, a little bit?
Yeah, I'm very mad. Like, this is not happening.
It's not, yes, it's not. And I will say, I've been a clinician for 13 years. I wasn't doing this, you know? You don't know better, or you don't do better till you know better.
What is expected in the first swallow study? Like, what kind of, at the very simplest level, like what kind of liquid do they need?
Depends on the kid.
Sometimes we'll start with purees, sometimes we'll start with liquids.
If you're doing like thin oatmeal or thick oatmeal or something
Bring
like
that.
Like, shouldn't we be practicing with that beforehand?
Yeah.
Yeah, Or if they're doing that at home,
Well, not
you can bring that to the
necessarily,
therapy.
You're talking about when you're in the hospital or when you're out of the hospital?
No, when we go to Saw Study and they give, that's what they're giving her to track this,
Yeah, the
Right.
barium.
But without him eating before.
We ask in my facility, we encourage families to bring your home foods. There's a rationale for that one. Now we're getting deep into it.
It depends if you're looking at oral motor or from an aspiration standpoint.
Yeah. Like purees are often much safer because of that cohesiveness and smoothness for it to be able. But it could be because some people can't tolerate that because they don't have the oral motor ability yet to take a puree, and so the liquids might be easier to kind of have them progress backwards. So that's why we have the luncheon, because I know that there's so many specifics, and one presentation on what a caregiver should do it's not for all of you.
So you need the oral motor first, and then you like.
If a child can get food into their mouth and initiate a swallow, then we can try to do the swallow study to see where we're at, like with that. And so if we can clear that the airway is safe, then we can be more more liberal at home if they're able, and then work on that oral motor. Yeah.
Okay, so something I really love, especially with our kids who have feeding tubes. So where does food go, right? We have to talk to our kids about eating. And even if we're like, they understand a little bit, talk to them, use simple words. Oh, I'm eating, mommy's eating, crunch, crunch, crunch. Oh, it's going to my belly, and keeping it positive. So this is a video I really adore. Which one, on here or on the computer? Then am I gonna have to, do I have to press F1, right? Okay. So this is a really great example.
Show me, does your broccoli fit into your G tube? Let me see. Does it fit? Yes. It doesn't fit. How are we going to get that broccoli into your belly? Can you show me how you get the broccoli into your belly? No, doesn't fit. Okay, show me. What do we need to do? Yep, you gotta eat it. Oh, there you go. Let's get
But that's the most beautiful example of how you can really advance some of how the therapy we're doing with our kids, because it's not just about food going in, but where does it go? And I really love that part of therapy, especially when kids don't have hunger cues. And I have a lot of kiddos on feeding tubes that have no hunger cues, and parents don't know what their hunger cues are. So that is something really empowering. But I want to talk a little bit, because you're in the hospital, you get discharged, you see a speech pathologist, or you do a swallow study, and then they're like, oh, these are our levels. And the big takeaway is that the levels are mostly for everyone to be on the same page. So if the kid is able to do thin liquids, we know what that means. If you're on a puree diet, you know what that means. You often hear thickened liquids. We are trying to transition, although you'll still hear us say, nectar thick, is now mildly thick. So there's a lot of different terms that still are kind of thrown out there, but it comes from this chart. So as we were talking about earlier, a smooth food like a puree ideally should move easier through the mouth, because it gives more time for the brain to go, okay, something's in, oh, get ready, brace yourself, swallow, right? Versus a thin liquid, it's boom, you have to be really quick. But on the contrary, water itself can be absorbed differently. If you have sugars in a food and that goes into the lungs, that's when you can run into some problems. So that's where it's the puree or the water, which one's safer? It depends on the child. Again, what does this mean? Baby steps for some of our kids. If I'm on a mildly thick liquids, I might not be able to jump straight to thin. I might have to do a transition of slowly in therapy and get you ready for your swallow study. Again, if I'm on a puree and we're eating pureed, whatever, rice and beans and chicken, that doesn't mean I'm gonna give you a rice and beans and chicken as is over here. There's baby steps that go moving up that ladder depending on your child, depending on their chewing, their cognitive skills, their alertness. So we want to be safe in helping these muscles learn how to eat higher level foods, but it's also not jumping steps, because I also want to be successful. So if we're doing really good here and maybe here like really mushy, but then your child is screaming and crying and spitting everything out when you go to regular, like back it up, right? I often talk about a staircase, and we just can't go from stair 1 to 10. We got to go up a little bit. The goal isn't to keep them at pureed forever. Some kids, unfortunately, are at pureed for a longer time, but in therapy, we should be challenging them a little bit. Promoting swallow safety. You'll hear this a lot of the time, recommendations, right? For positioning, we want to have good head support. We'll often talk about 90-90-90. Some of our kids that are in custom wheelchairs, that really promotes a good supportive system. We don't want to be hunched over or like leaning backwards. Pacing, that's just like making it go slow. We want to prevent overstuffing and food getting lost in those chipmunk cheeks, because that's dangerous as well. We just talked about food textures. And then, you know, with supervision, that's to keep them safe, right? We don't want to leave some of our kids alone with just food and not knowing like what's going to happen. And safe swallowing is not about eating fast. It's about eating smart and calm and with confidence. So tips for managing feeding challenges. Some of our kids, Mom was telling me this today, that her child gets fatigued during a meal. And so we were talking through some strategies on that one. But really, like, we can't have hour-long meals. Like, that's exhausting, not just for you as the parent, but also for that child. So having smaller meals is going to be more beneficial and more positive. Distraction and focus feeding. This is a hard one. I'm not going to lie. I know people eat with their phones out and the iPads out and the show's on and stuff like that. But like, if we really want to build the connection to food, our focus needs to be on it. Another one, avoiding force feeding. The more positive the meal, the more willing your child may want to eat it. So if you're going down that route, we need to figure out what we can do to manage it, even if it's through a play-based strategy to get your kids to eat. When nothing by mouth. Okay, so that doesn't mean your team has given up, okay? I do want you to be aware of that. It just means that for the moment, your child may need to heal, and we want to give the body time to heal and protect their airway. But we shouldn't be NPO we don't necessarily shouldn't be NPO forever, but in that time when your child might be nothing by mouth, we should be doing other things. Like, there's no reason you can't be kissing food and like putting it on your lips maybe, or smelling it, and definitely brushing our teeth and doing oral hygiene. You know, and then another one, you know, will my child eat again? That's a really hard one, and every child is different, but we still need to work on our skills and our oral motor development, even if food isn't there in that moment, and then we start bringing it in. But we want to be safe, right? We would never want to risk having to go back into the hospital, but every child is different. So the barriers. This one gets me like really wild up, because I'm in the homes and I'm at schools. I actually go to quite a few schools in the Houston area. I have some kids with G-tubes, and I'm like, oh, where are you getting your feed? And it's like, oh, well, the nurse has to give it in the nurse's office. And I'm like, you're not at lunchtime with your friends? You know, but like, that's the reality of it. And so like, then we take the social piece out, and then, you know, but it's like, how can I help that? But like, that makes me really sad. And then when you have your kids that are eating at lunchtime, and there's not enough time for them to eat. So you have to kind of problem solve some of that. Home health nurses, again, I go into homes and I'm like, oh, nurse, are you giving him some of those taste of purees? And she's like, no. Okay, I need a doctor's order. I need a swallow study. I'm like, what do you need a swallow study for? Like, really? So then it's like, it takes us 3 months to get the doctor to write a note that says, you know, the kid can take 3 tastes of banana Gerber. And I'm like, but that does happen. And then tube schedule conflicts, as Taryn mentioned, right? We've got to kind of figure out a happy medium. So troubleshooting at home, again, taking away the pressure is kind of the big takeaway for that one, and just making it fun. If you're sitting at the table eating, if you can get your child, even with a tube feed, going at the table and just getting some of that time there with you, that is good modeling. So I know we're kind of running out of time, so I'm going to go quick. We talked a lot about this already, but just being advocating for your child and knowing that asking questions really gets conversation going. And state your goals. And maybe sometimes parents' goals are a little high, and I gotta kind of like meet them in the middle. But then we come to a point where we're like, I'm here to help you. If my children are talking, I ask them their goals, right? If they're using an AAC device, you know, we're going through the foods on there and we're trying to figure out, well, what do you want to learn how to eat? Empower. And so we will have our lunch and learn tomorrow, and you can start thinking about this, but we have a couple minutes. Like, what are some barriers? I know you definitely have some. You've brought up some. I think it's more like frustrating that you like don't know what you don't know, but that's why you're here to learn and to figure out like, what can I do? What are the questions I can ask? If you have specific things, absolutely tomorrow. But yes, no. Please.
No, and now.
We have a few minutes.
Now.
Well, so like I said, 5.5 years since the accident. I'm wondering, do you guys, speech therapists that understand the brain injury, that do y'all have like a website somewhere? Because I've had a speech therapist almost kill my son with a dum-dum. Made zero.
These are our contacts. Our little GIF that we just did. We have that, and
I'm in Fort Worth. I heard you're in.
We're both in Houston.
Both in Houston.
But I have people in Fort Worth.
You do?
Yeah, I got people everywhere.
I've had really, really bad luck.
I can imagine. That's why we're here.
Yeah.
So happy you're here.
And these are some resources.
Your link has feeding therapy supplies. I think people have been coming by the table and seeing some of the things that
so
she
this
has.
link on my Instagram, Little Eaters Talkers, I have all this also. So you go into my link tree, and then I have different things for feeding supplies to kind of maybe tell your therapist about.
Take a picture of some, here's some tools.
Have y'all ever seen this before? When we come at my son with food, he bears down, and the more he wants to open his mouth, the tighter it shuts. So then I take the food away, and then guess what he does?
He's sad. He wants it. His
He
body's
wants
not going
it.
to react.
But then I can't give it to him because then I'm afraid he's gonna go and suck it in. So I don't know how to get past that. No one has been able to help us get past that.
I mean, I know what I would do, but yeah. No. Well, for that, you have to start with, is he at the table when you're eating?
Every
right,
night.
modeling. And does he have food in front of him that he could, I don't know what his limb movement is, right? But
He's in a wheelchair, and when he wants to come forward, he goes backwards.
can he move his hands to some extent?
It's some apraxic.
I mean, he's very.
Yeah,
I can tell
that's
apraxia
apraxic
for sure.
there.
But then with that, you have to go through the 5 senses too, right? Hear, smell, taste, see, right? So if he's seeing the food, that's one thing. Feeling the food
When he
isn't.
sees it, he gets real drooly.
He's right. He wants to eat. Yeah.
It's so.
And so apraxia, in the way, it's the general definition is motor planning. And so he wants to eat it, but then his body, the motor planning of that is doing the opposite or not what he's intending to do. And so having someone be able to address and work on that in a multidisciplinary situation, how's physical therapy, how's OT?
It's just.
And they're not, we're,
If they can't hold hips and help someone walk down the hall, we're not getting what we need.
yeah. There's a special,
So
our
even-
information.
Have you met the table from Napa?
I have not talked to Napa yet, only because my son is still struggling to even sit up.
They do some really cool stuff at Napa. Yeah.
We have
There's
the
some
table.
really cool projects
They have
out there.
intensive programs.
Yeah, you don't have to sit up to go
I
there.
thought we would.
Thank you guys, I appreciate it.
Yes, please reach out to us. We're at the table.
But sometimes, and they have a whole team approach